You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Welcome to this episode of International Perspectives on Chronic Ocular Surface Pain. I am your host, Anat Galor. On this series, clinicians from around the world are going to discuss chronic ocular surface pain, what it is, its underlying causes, and how to treat it. In this episode, we're going to explore the underlying causes of chronic ocular surface pain. If you're curious about defining chronic ocular surface pain, go back to the first episode of the miniseries, during which we characterized chronic ocular surface pain and discussed common clinical presentations. And now to our panelists. I'd like to introduce you to Dr. Pedram Hamrah, who practices at Tufts Medical Center in Boston. Dr. Hamrah, thanks for joining us.
Thank you so much for the invitation to participate in this podcast.
And also joining us today is Francis Mah, who practices at Scripps Clinic in La Jolla, California. Dr. Mah, thanks for coming on to the show.
Yeah, thanks a lot, Anat. Really, it's a pleasure and an honor to be part of this with you and Pedram.
And really, I'm so glad to be speaking with both of you because you guys are really leaders in this field, and I can't wait to hear about some of your thoughts. And so maybe Dr. Mah, you can start us off talking to us a little bit about when a patient comes to your office and they have chronic ocular surface pain, what are they actually complaining about? What are the symptoms that they come in with, and what do you try to elicit?
Yeah, that's, I think, a fantastic starting point. So as far as the general chief complaints or, how the patient presents, it's essentially corneal pain or some type of ocular surface pain of varying severity. It could be, something that just sounds excruciating, or it could be something that's slightly milder or more chronic. All the symptoms generally kind of sound like dry eye symptoms. So foreign body sensation, burning, reflex tearing in general. And again, some people may be a little bit more histrionic, some people may be a little bit more emotional. There could also be severe photosensitivity. There could be allodynia, dysesthesias, all of these various different kind of corneal or ocular surface pain. As far as other, symptoms, it could be facial dystonia, blepharospasms, all of these different things, can definitely be part of the symptomatology of the patient's headaches, migraine types. So it's a lot of discomfort, pain, things that we would in general think of as corneal pain, or definitely ocular surface pain, but more kind of corneal pain in general is what the symptomatology or the chief complaints tend to be like.
So Dr. Hamrah, we just heard a long list of things that people can complain about, whether it's dysesthesias or burning or tenderness or foreign body sensation. Can you use any of these complaints to try to figure out what the underlying cause of ocular surface pain is, thinking about ocular anatomy?
That's challenging because it depends on the stage of the disease. I think in the beginning, the pain can be more localized in the cornea, particularly if it's post-surgical. But once the disease progresses without treatment, then the pain starts spreading to the rest of the eye, behind the eye, around the eye, periocularly, and then also, as Dr. Mah mentioned, in shape of migraines, etc. So the symptom itself, it's hard to be associated with a particular cause, because all the different etiologies, which we're going to get into in a little bit, can present very similarly. So I personally haven't been able to discern that a particular etiology results in a particular type of symptoms.
That's fair, but maybe take a step back and tell me, what are some of the common underlying causes?
The common underlying causes can be ocular, in terms of ocular diseases. So these will include a typical dry eye disease, more inflammatory diseases of the eye, such as Sjogren disease, corneal ocular infections, herpetic disease like herpes simplex or herpes zoster. They can be diabetic, And when you go down to the more surgical causes, any eye surgery can result in chronic ocular surface pain, but most commonly cataract surgery, which is in a milder shape or form, but also refractive surgery such as LASIK or PRK can result in more severe form of ocular surface pain. And then we have the systemic conditions such as small fiber neuropathy, radiation keratopathy, and associations with depression, anxiety, medication-induced induced eye pain, etc. So the list goes on and on.
Dr. Ma, I love to tell my residents that we're doctors first and ophthalmologists second. So tell me, what are the most common systemic conditions that you find in your patients with chronic ocular surface pain?
Yeah, that's I think this is an extremely essential part of chronic ocular surface pain, corneal pain, neuropathic pain, whichever term you'd like. And I think the reason is because, as you said, it's really the history taking, and that's something that's it's essential in medical school. Is history taking, and as Pedram kind of alluded to, it's really making sure to cover the various different causes of potential corneal neuropathic pain. So some of the systemic things, that you would think about, diabetes is one of the more common things that Pedram mentioned. The other things would be, again, like Pedram mentioned, that small fiber neuropathy. Multiple sclerosis is another one that you can definitely think about. Trigeminal neuralgia is another kind of a bigger area. Fibromyalgia, can definitely cause these kind of things. Systemic drugs, that also is another systemic type of issue, and anything that can cause systemic neuropathic types of pain syndromes can also cause this corneal neuropathic pain.
Well, that was a very comprehensive discussion. I think this is a good point to take a break and continue this conversation on the other side with the focus on the particulars of examinations for this patient population. Thank you so much for your insights. Welcome back to International Perspectives on Chronic Ocular Surface Pain. We've been talking about the underlying causes of chronic ocular surface pain, and I'd like to learn more about how our panelists examine a patient who presents with complaints of chronic ocular surface pain, no matter what the particular complaint is. So I thought Dr. Hamrah can start me off. So what elements of an examination are unique? Are there things that you do specifically in patients with chronic ocular surface pain?
That's a great question. One of the more unique components of the ocular surface pain patients are the history taking. While in ophthalmology, we used to observe patients on slit lamp and diagnose and treat, the history is particularly important in these ocular surface pain patients. These include the time of the pain that's developed, the inciting stimulus, any surgical history, medical diseases, ocular medications they've been taking. And particularly also a review of systems is very important because it can lead you to aid in the diagnosis of any additional systemic diseases that may be comorbid diseases such as small fiber neuropathy or autonomous nervous system problems, anything related to the nervous system, basically. Beyond that, I think the timing of the pain, the pattern of the pain, the frequency, the severity, the range, quality of life issues, and particularly also the type of symptoms all may aid in deciding what kind of plan and prognosis one can discuss. In addition, there are several components in that as a result in terms of nerve function testing. We usually, in my clinic, we use like a hyperosmolar 5% sodium chloride drop to kind of stimulate the nociceptors to see if there's a hypersensitivity in these patients or hyperalgesia. And we also use a numbing drop like proparacaine to discern whether the pain is ocular or non-ocular or a combined source of the pain that's basically would potentially require systemic and or ocular treatments. We also use confocal microscopy to look at the nerve morphology in these patients to assess whether there are, for example, abnormal morphological changes in these patients as well. And that also may result in showing inflammatory component of the pain in these cases. I think the rest of the exam is similar to any dry eye patients as well, but these are the kind of more unique components that we use for examination of these patient population.
That was very thorough. Dr. Mah, what about you? Are there any particular tests that you find useful in characterizing chronic ocular surface pain?
Yeah, I think, Pedram really did a very well summary of the specifics specific to corneal pain or neuropathic pain. But a couple of things. One is there is a verified ocular pain assessment survey, which you can use to quantify the pain and impact on the quality of life. It's kind of similar to, for example, OSDI or SPEED for dry eye, but this one is much more specific to ocular pain. I think the other things, just in general, I think the proparacaine test is very important, as Pedram mentioned. And just to, kind of go into it in a little bit more depth, it does differentiate between peripheral, which is more local. So if you get complete relief of proparacaine, which is what we normally think of in eye care, then that would be a more local phenomena. Whereas, if you don't, or if you just get modest relief, then that's probably a central or more systemic, kind of an issue. I think the other thing is, as far as the confocal microscopy, I think those are very, very unique in general. Confocal is not unique, but looking specifically at some of the findings in terms of corneal epithelial changes and obviously the nerve changes. But in general, you kind of do an ocular surface workup, as Pedram mentioned, and then I think those three things, the survey, the proparacaine test, and then confocal are kind of a little bit more specific to looking at chronic ocular surface pain.
So, Dr. Hamrah, this may be a tough question, but you gave me a long list of things that you do, and I think it's fabulous. But is there one or two that you think are most important or that you weigh most heavily when examining these patients?
I think in terms of diagnostic, in order to assess which treatment to put the patient on, for me, one of the most important one is the proparacaine test, challenge test, because that tells me whether I can treat the patient with ocular treatment or require systemic. That's number one.
Can you take me through that? How do you actually do that test?
So we basically, we use it in combination. So what we do is we have a patient come in, they sit before we put any drops in. We ask them what the pain level is in each eye. If they can tell, we record that. Then we put a hyperosmolar test in the eye. We wait 20 seconds, ask again the level of pain. And in the patients who have inflammation or neuropathic pain, usually the pain, that if it's peripheral, goes up by at least 2 points or higher, which kind of results in suspicion of hyperalgesia. Then we put the proparacaine drop in each eye at the same time and wait 90 seconds. And then we ask again for the level of pain. And if the pain has gone down to zero, that concludes that this is purely peripheral pain. If the pain comes down partially, as Francis said, but not fully, we think that's kind of a combined source, where we have both some non-ocular and ocular source of pain. And if the pain doesn't budge, or if the pain actually increases, that's typically purely non-ocular pain, and that can be a ganglionopathy from the trigeminal ganglion or more central nervous system as well. In those cases would require more systemic treatment. The second test that's very important for me is the confocal, because for two reasons. One, it shows us the cellular inflammation, because there's otherwise hard to see the subclinical inflammation, and that will allow us to that decides whether we use the patient on how much anti-inflammatory medications we use. And we can also look at the nerve density and the morphological changes, assessing whether we need to have some more regenerative therapy like autologous serum tears or other things, which would kind of improve the nerve function or improve the nerve homeostasis in these cases. And then the third would be the level of pain these patients are in, because then also we can decide how aggressive we should be with these patients. And while in dry eye treatment, we typically use a step-ladder approach and gradually work ourselves up. In more severe cases, I use what I call the reverse step-ladder approach. We kind of put the patients on multiple treatments to get them comfortable and then start removing the different treatment modalities.
That was very helpful. So Dr. Mah, you've diagnosed a patient with chronic ocular surface pain. How do you talk to them and discuss their condition, the pathophysiology?
Yeah, I think this is extremely important because a lot of these patients, as both you and Pedram know, have seen typically multiple specialists, multiple physicians. And, I think a lot of times, these issues unfortunately get dismissed. So I think the first thing is just to tell the patients, that you've seen other patients like this, that this is a real condition, that, we call it, and, you can call it whatever you normally call it, whether it's ocular neuropathic pain, whether it's corneal neuropathy, corneal neuralgia, keratoneuralgia, whatever term people use in their own clinics. But in terms of why it happens, in general, the way that I explain it is there's kind of this repeated damage or repeated stimulus to the nerves. And generally, it's not really painful stimuli, but there are stimuli to the corneal nerves. And this repeated stimulus and this repeated chronic, these episodes result in damage to the corneal nerves. Could be surgical, as Pedram had mentioned before. It could be some type of aberrant regeneration as well. But in general, you've got some type of damage to the corneal nerves. This results in upregulation of nociceptor responses for processing pain stimuli. So that means the bad receptors, if you will, in the nerves. And that leads to hyper response or increased sensitivity to the perception of pain in response to even normal, unpainful stimuli. So everything looks healthy, everything looks good. It's just that this is a nerve issue, and it's a result of multiple or chronic, kind of hits to that nerve. And now the nerve is kind of excitable and hyper sensitive.
I want to thank both Doctors Hamrah and Mah for an excellent discussion. Thank you for coming onto the show, and thanks to the listeners for joining us as well. This is the end of the second episode of International Perspectives on Chronic Ocular Surface Pain. If you missed episode 1, go back in your podcast feed to catch up. And if you liked what you heard, be sure that you're subscribed to the podcast so that you can catch episode 3 as soon as it drops. For now, I'm Anat Galor. Thanks for listening.